Hi everyone. So I am Dr. Deeksha Pandey, additional professor in the Department of Obstetrics and Gynecology, KMC Manipal, and I am also the in charge of subdivision of Urogynecology in our department. Today we are going to discuss a case which is so important and has become more important now as the expectancy of life of women is increasing, and many women 2 to 3 decades earlier have already undergone hysterectomy. So, can you guess what case we are going to discuss? Yes, this is the case of wall prolapse. And to discuss this case, I have with me Dr. Vaishnavi. And Dr. Vaishnavi is a final year postgraduate in our department. So, she'll present the case, then we'll discuss how to go about it and how to manage these kind of patients.
So we have with us a 67-year-old Mrs. X, para to living to, homemaker by occupation, who was hailing from Udupi and belonged to middle socioeconomic status. She came to complaints of mass descending per vaginum since 15 years and spotting per vaginum since about 15 days. So basically it was spotting per vaginum that had got her to us. Moving on to history of presenting illness. She was apparently asymptomatic around 15 years ago when she started to develop a mass per vaginum. This was insidious in onset and progressive in nature.
So this mass was there for last 15
years.
And bleeding was there only for 15 days. Okay.
Now, this mass increased when she walked, performed any kind of exertion, and it reduced when she lied down. She was able to reduce the mass, but however, as the time progressed, she was having increased difficulty to reduce it. She also complained of lower backache, which was dragging in nature, and this also improved when she took rest or she lied supine. Now, she had complaints of multiple episodes of spotting PV on and off. The blood flow during these episodes was scanty and bright red in color. It was not foul smelling. She had no complaints of pain per abdomen. She had no complaints of incomplete voiding of urine, difficulty in initiation of stream, narrow stream. She had no complaints of increased frequency of urine or burning micturition. She had also no difficulty in evacuating stools, like no constipation, no loose stools also. She had no complaints of fever, white discharge per vaginum. She had no history of chronic cough and no activities that could have involved lifting heavy weights or exertion involving basically a lot of lifting activity. She did not have. She had no history of recent significant weight gain or weight loss. She told that her habitus had always been like that. Moving on to past history, there is no significant past history. Menstrual history is that she attained surgical menopause around 20 years back when she underwent abdominal hysterectomy, following which she did not have any episodes of bleeding per vaginum until this episode 15 days back, which was scanty and episodic. Obstetric history, she is para 2 living 2, and both the deliveries were full term normal vaginal deliveries. The last childbirth was around 46 years back, and she did not undergo sterilization after that. Amongst her both deliveries, she does not give history of any prolonged labor or application of instruments. Then moving on to medical history, she is a known hypertensive since 3 years and is on treatment for that. And she recently during admission got diagnosed with diabetes and was on oral hypoglycemics for that. Surgical history is important for her as she underwent total abdominal hysterectomy in 2002, that is around 20 years back. She says that she underwent it because of prolapse only, but like she underwent it through abdominal. She also underwent incisional hernia repair in 2005 at our hospital only. So, moving on to her personal history, she consumes a mixed diet, has normal sleep and appetite, and no addictions.
So here we take a pause at the end of the history, and I must congratulate Vaishnavi that presented a very clear cut. No extra thing, but everything, whatever was required. And this is a message for all the undergraduates who are listening to this, that history should be clear cut. So if the examiner has confusion, they will stop you in between. Okay. So what I understood is Vaishnavi, that patient has basically three kinds of complaint.
Yes.
She presented because she had a postmenopausal bleeding. For last 15 years.
15
For
years.
last 15 years, she is having a mass which looks like some pelvic floor disorder,
Yes.
some kind of prolapse.
Yes.
But as she has undergone already hysterectomy, it must be a wall prolapse. But everything is fitting into prolapse. I do not have a doubt. Now, if prolapse comes with bleeding,
Yes.
what is your differential diagnosis?
Ma'am, it could be a decubitus ulcer.
Yes.
Over that.
I think only one thing comes to my
yes,
mind. Okay, prolapse presenting with that is like first diagnosis, and maybe 80% of the times it is a decubitus ulcer. And on top of that, when it is a long-standing mass, the mass is for last 15 years, so it is very likely that she has developed now a decubitus ulcer. Okay, so this is one thing. Then she told a few more things. One thing you told that she had backache.
Yes, ma'am.
Okay,
yes, ma'am.
So backache, does it get relief after she lies down? She
Yes,
told
ma'am.
something like
Yes,
it can be because of aging also, but when a prolapse patient tells of backache, what you should suspect? Which component?
Like the uterosacral.
Uterosacral. That means enteroceal component.
Yes,
okay. Whenever a patient says that she has backache, usually to start with, prolapse cases will not have backache. But when a patient specifically tells mass per vaginum and backache, you have to think that she might be having an enteroceal because of stretching of the uterosacral ligaments. It's there.
Yes.
So till now we are very clear about everything. Some little confusion is there. You said surgically. Usually prolapse patients are treated when we do hysterectomy specifically. We do, but there is no hard and fast rule. Because you can do laparoscopic also, and maybe somebody did it. I don't know whether they combined it with repairs or not repair. For that, you need to have good notes, or at least you should explain patient what all you have done, so that next time patient goes to the hospital. So this is a learning lesson for us also, that whenever we have to give her proper documentation of what we have done. Because as I told you in the beginning also, that now the life expectancy of women is increasing. And many women have already undergone hysterectomy in last 2 to 3 decades. It is again a big issue nowadays. So patient will come, more and more patient you are likely to see with wall prolapse in your clinical practice. So whenever you do a prolapse repair especially, you have to tell properly that what all you have done, which route you have obtained, what was your idea. You have to document and let the patient preserve it later if she gets into any trouble. Okay. So till now here we are clear. But again, this is just history. We have to examine the patient and find out whether what we are thinking in our mind, it is correct or not. So we'll proceed to examination.
When we examined this patient, her general condition was fair. She was well built and nourished. Her weight was 60 kilograms, ma'am.
I think she was on the obese side. Okay. BMI?
BMI came to 24.4 kg per meter square. Then, ma'am, her thyroid and breast appeared to be clinically normal. There was no evidence of pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Vitals were stable with a pulse of 82 beats per minute, BP of 140 by 90. CVS and RS were normal, ma'am. Moving on to the per abdomen examination, her abdomen appeared to be normal. It was not distended to look at. However, she was obese. There was abdominal fat.
And abdominal laxity and fat, because those things are important for us. One thing I think we missed here for this patient, not spine you will tell in examination. In history, did you tell the sensational hernia thing?
Yes, ma'am.
Okay, so this is again, I did not tell about it. So she has undergone a hysterectomy. After that, she has also undergone an incision. This tells that patient has some weakness of her collagen tissue. So this is again one of the markers, one of the positive points in history, which brings us to this thought that maybe now there is pelvic floor relaxation. Okay, so whatever factor, it is that weakened the abdominal wall so much that she has developed hernia there. She is even more likely to have weakening of pelvic floor and developing some prolapse.
So on abdominal examination, we found that abdomen was not distended. However, laxity was noted. She was obese also.
So you have to check for hernia also now. Okay. So because maybe just after once, even if you repair 5 years, 10 years ago, there is always a chance that recurrence can be there.
This time, ma'am, we could not elicit hernia. There was no presence of hernia. Then it was not abdomen was non-tender on palpation. We could see a well-healed midline vertical scar up till the umbilicus, and also a Phanon-Steel scar was there. So probably the Phanon-Steel was for the hysterectomy, and the incisional hernia repair was done by midline vertical. So that's all. Bowel sounds were well heard. Moving on to per speculum and per vaginal examination. So we examined this in as per compartments. So when we examined for the anterior compartment, we could note a midline defect, that is grade 4 cystocele was present, ma'am. The cystocele was beyond the level of introitus, and we could not see any vaginal rugae over it, which confirms that it is most likely an anterior midline defect. So the midline defect will not have vaginal rugae, whereas a lateral defect will have vaginal rugae preserved. Then lateral sulcus
Okay, so this thing, we'll just go and you have examined the patient.
Yes, ma'am.
Okay. So wall prolapse is more or less the examination is similar to a case of prolapse. Okay. So first thing I have put a video there for examination of prolapse. I suggest all of you to go and see that. Okay, it is a because prolapse examination is little more than a routine gynecology examination. Usually routine gynecological examination you do by doing a speculum examination, vaginal examination. But there are 5 steps in a prolapse examination, okay? So first thing you have to observe the mass, okay? So one thing, first you have to confirm. See, when we are thinking prolapse, it can be something else also. It can be some cyst, it can be some tumor, anything. So first, very important thing is you have to see the size and shape of the thing, and then cough impulse, which will clinch your diagnosis of pelvic floor disorder. Okay. In history, you have specifically said that whenever increase intra-abdominal pressure is there, mass increases. Whenever rest is there, mass goes back. But that you have to see with your own eyes. When so you have to do a stress test. You have to tell for the patient to cough. If it bulges, okay, we call it cough impulse, is present. If cough impulse is present, it's very likely or it is 100% diagnostic of a prolapse. And in this particular case, as hysterectomy is also done, we have no confusion. It is a case of wall prolapse. Okay. Then what is the second thing? Then with wall prolapse, you have to see one more thing. You have confirmed wall prolapse. In that time, you can see SUI also. Okay. Sometimes SUI gets seen only when you deposit the mass back. But here also, if you have to stand on one side, because some patient will demonstrate SUI even with this test. Yes. Okay. With the mass hanging outside. Then now prolapse is simple because there is a cervix, there is an anterior compartment, there is posterior compartment. But if you have examined cases of wall prolapse, it's just like a bag. Okay, it's so difficult to find out. It's not easy to find out what is anterior compartment, what is posterior. So there is a trick to do that, and Vaishnavi knows that trick. What is the trick?
To identify the vault line, the suture line.
So if you see it carefully, if you hold the mass in your hand and try to locate carefully, in 100%, and trust me, I'm saying 100% of cases, you will see a scar line. Because whether it is abdominal hysterectomy or vaginal hysterectomy, the vault would have been closed. Even if it is not closed, even somebody has followed TLNs and not closed it, then also it will heal. It has to heal. So there always be a scar, and many a times, in 90% of the cases, there will be dimpling because uterosacral gets attached there. Maybe the person has attached, the surgeon has attached it intentionally, or because of adhesions, because of in the process of healing, it gets attached there. Okay. So very clearly you will see a scar line there and 2 dimples in most of the patients. Okay. So what do you do now? Whatever is in front of that is cystocele. Whatever behind that is enterocele. Correct. Okay. Rectocele is not the part of this bag. To see the rectocele, you have to lift the entire mass with the help of a speculum and tell patient to cough or push. Then see a bulge which is arising from the lower third of the vagina. Okay. To confirm that, you can put a finger in the rectum and see whether it is indenting in front or not. Okay. So this is, in short, the examination of vault prolapse. Okay. So this thing, what important thing I want you to understand that most of the patient post hysterectomy, if they come with a prolapse kind of system, most of the times, if I have to give a percentage, maybe 90% of the times, they all will have apical prolapse. Okay, they will not come with isolated cystocele, isolated rectocele. I will not say they will not come, but maybe that percentage will be less than 10%. Okay, Vaishnavi?
Yes.
So what is the more important implication of this statement? That all patients who come post hysterectomy prolapse are wall prolapse or apical prolapse, not isolated cystocele. This has a very important indirect meaning that if you have fixed the wall properly during hysterectomy, in all unlikely they will have it. Is very rare to have a prolapse post hysterectomy. We now also call it wall prolapse, is also known as post hysterectomy vaginal wall prolapse. This is the entire new name for that. Okay, so usually if you have fixed vault nicely, that's why we emphasize so much in fixing the vault at the time of vaginal hysterectomy specifically, because vaginal hysterectomy patients will have more. Okay, tell me this thing. I give you 3 patients, A, B, C. A patient has undergone abdominal hysterectomy for some fibroid. B patient has undergone NDVH for fibroid.
Okay, ma'am.
C patient has undergone vaginal hysterectomy for prolapse. Which patient is most likely to develop wall prolapse?
And the third patient is more likely.
Very good. So already tissues are weak. Okay. Now this patient you have to really counsel for risk of wall prolapse. Now among the two, for fibroids, one patient has undergone NDVH, other patient has gone abdominal hysterectomy. Which patient is more likely to have
NDVH patient?
NDVH patient, correct. Why? Because when actually we are doing NDVH, we are giving too much traction. So maybe iatrogenically there is no true evidence to prove this. So NDVH still remains a very good surgery. I am not saying that it will have. But when they compared the incidence in same kind of conditions where abdominal hysterectomy versus NDVH, they saw a slight increased risk of wall prolapse later. So we have to just keep this in back of our mind. But still NDVH is a beautiful procedure, and wherever possible it has much less risk of other complication. We should resort to it. Okay. Now coming back to our prolapse examination we have done.
Yes, ma'am.
So this patient now had what? You could see the wall there?
Yes, ma'am. We could see the wall.
Now here is the very important thing, that why we have to quantify. So many times we say that quantification POPQ. Okay. So POPQ is very important in these kind of cases, because if somebody tells this was outside the introitus,
yes,
okay, you will see, because here there is no uterus to say that procedential anything. So you will say it was, if you go through conventional system, you will say it was a grade 3 wall prolapse. But if you look at the prolapse, maybe we'll post the video of surgical video sometime later. So if you see that prolapse, it was like 10-12 centimeters outside. So that prolapse, which is just outside the uterus, that also is 3rd degree according to conventional. This is also 3rd degree. You cannot compare both the things. Okay. So it is very important that in these, at least even if you are not doing entire POPQ, at least measure the prolapse size, so that you will be able to tell and you will be able to manage it properly. And then follow up also. It is important that how to decide how much what is the result of your surgical treatment or recurrence if it happens. Okay. Then one thing you did not tell, or you have to still tell the examination, or prolapse examination you have finished?
Prolapse, the decubitus ulcer.
Yes, that's what. So she had a
decubitus ulcer, ma'am, around 4 into 2 centimeters, ma'am, on the left lateral wall of the prolapsed wall. And although like she had complained of bleeding from the same side, but now it had healed when we had examined this.
Because we have given
her
treatment.
We
have given her what we have given her?
Antibiotics and compression.
So no antibiotics. So these are not infective ulcers, you have to remember. It is because of venous congestion. So it is a friction and venous congestion ulcer. So there is no need of antibiotics for that. The best treatment is the reposited part. But for this patient, prolapse, can we reposit prolapse with pessary?
Yes, ma'am. Yes.
And the prolapse means wall prolapse?
Yes, ma'am.
No. It won't happen. Okay. Because still there is cervix and the paracervical ring. Maybe paracervical ring of ligament should be there. Then you can fix the pessary. Wall prolapse you put in few hours, it comes out. And this kind of prolapse, when so much abdominal is putting pressure, There is no possibility that the pessary will remain inside. Something needs to hold the pessary. This patient had big introitus and no support, so even if you put it as a waste, okay. So healing can be, so you have to just teach the patient to put it reposited back. You cannot put a tampon also.
Yes, ma'am.
Because if she forgets to take it out, then
We
there
are
is
focused.
problem. And on more so that it will come out, like pessary will fall, tampon will also fall. So we educated the patients whenever possible to take rest, and whenever night she is lying down, she has to first reposit it and then go to sleep. Okay, as much as possible, self-reposition was taught to patient, and simultaneously Avalon cream was given to patient. Okay. So this was the treatment. So now it was after 1 month, I think
Yes,
patient
ma'am.
came to
Yes,
us,
ma'am.
it was more or less healed. Okay. Not 100%, but more or less. We'll come back to it later when we are discussing surgery. Okay. And then this is the examination. Okay, so Vaishnavi, you have not told till now. So we were discussing that we have to, it is important to quantify. So it was around 10 to 15 centimeter. We did not measure exactly. Actually,
Yes,
we should have done that. But it was a huge mass which was hanging outside. Okay. Now, if I ask you, how do you define vault prolapse? Because it can be, just saying vault prolapse is not enough. Okay. Because if you look at the definition, it can be very small to very big. So when you are deciding the treatment, the size is very important. Okay. So what is the definition of vault prolapse?
Wall prolapse is defined as the descent of the vaginal wall 2 centimeters beyond the initial, like the word is basically like it
2
is
centimeter less than
the
the total
vaginal length. Yes, ma'am.
Okay. So that means, what does it, if I put simply, it means that normal vault was there. If it has drooped down 2 centimeters, then it is vault prolapse. So vault prolapse, that patient also is vault prolapse. 15 centimeter outside also is vault prolapse. Okay. So usually vagina is 10 centimeter, but when it stretches so much because of the intestinal and bladder all content, sometimes stretches and can become very long, more than 10 centimeters, as was for this patient. So coming back to the definition, so this is the ICS definition of vault prolapse, which means that if the prolapse, the vault comes down from its normal position just 2 centimeters into vagina, from that moment you can say it as a vault prolapse. Okay. So how they define it, this is the understanding and definition is, if the vault is 2 centimeters less than the total vaginal length in POCU. Okay, that or beyond that is a case of vault prolapse. So can you tell Vaishnavi, how do you measure total vaginal length in POCU?
The total vaginal length is from the introitus,
from the hymen.
hymen.
In POCU, everything is hymen.
From the hymen. From the hymen till the.
So important thing you have to remember that in POCU, everything, whatever component, 9 components you take, out of that, 8 components are taken when the patient is pushing down.
Yes.
Total vaginal length is the only length which has to be taken when the patient is not pushing. So you put your spatula or your scale, whatever you have made, and you measure what from where it goes till
the hymen.
Okay. Suppose that is 10 centimeter. Then you tell patient to push or cough. Then the bulge you measure. You have to put speculum if it is still inside. Okay. So you have to measure. Suppose it comes 6. That length. Total vaginal length comes 10 and this comes 6. So what is vault prolapses?
More than.
How do you write vault prolapses? Inside. So it is minus 6. But it is a case of vault prolapse. Okay. Anything which is less than 2 centimeter less than TVL is a case of vault prolapse. This was around 10 to 12 centimeter outside, means plus 12. Okay. Yes. Understood this? Yes. Okay. Then what? Then how do you decide? So anterior rectocele, I have told you. If rectocele there is a confusion, then you do a parental examination for indentation. Okay. So actually this patient did not have much of rectocele. She had a lot of a big cystocele and a big enterocele, and vault was totally prolapsed out. Okay. Now, what do you want to do? Any investigation you want to do? Routine investigation for fitness you have to do. looking this prolapse, can she have some complication that you want to check?
Any precipitating factors for that? Smear,
No. Wall smear also hysterectomy done in 67 years old. Ulcer has healed. That is the trial of treatment. If it is a non-healing ulcer, then you have to take a biopsy. If you're with your conservative measures, ulcer seems to be healing, then it means it is a decutaneous ulcer. So I'm not thinking of vaginal cancer in this patient. When the wall pulls down, can it pull with it some tubes?
Ureter, it can.
Okay, so we had seen many patients with wall prolapse lesser than this patient who had developed hydronephrosis because kinking of ureters. Because wall, whenever it comes, bladder comes down and it will pull the ureters and ureters will get kinked and stretched. Okay, so then it will cause hydronephrosis. So what investigation is required? Ultrasound. Abdominal ultrasound, let's screen everything, whatever is inside and see, because ultrasound abdomen will pick up hydroureter nephrosis. So this patient did not have any hydroureter nephrosis. Then that investigation, then you, what is the plan of treatment?
Ma'am, like there are different approaches with which.
Before that, you have already told me that pessary is not going to work.
Pessary is not going to
You should not even try for prolapse, because even somehow you put a big pessary and put it inside, first thing, 2 days after it is going to come out, sorry. Then in this thing, even if you put a bigger side pessary, then you have more risk of erosion on the side.
Yes,
so never you should put a bigger pessary which compresses on the walls. Okay. So pessary, as per as my experience, though it's written in books, but as per as my experience, for wall prolapse, pessary never works. Okay. Then maybe we are seeing bigger prolapses, maybe for small prolapse it will work, but what kind of prolapse we see, pessary does not work for that prolapse at all. Okay, then tell me.
And then we can perform treatment for wall prolapse.
Pelvic floor muscle training, will it work?
But not for this prolapse. It is very big.
Very big, it is not going to go inside. Okay, and on top of that, 67-year-old lady who is obese, you know how her compliance with connective tissue already gone, hernia on one side, how much tone her muscles. So actually you have to see pelvic Oxford grading also to see, but it won't work. So you have to go for some surgical correction. So when it comes to surgical correction, what kind of surgical correction you can do for wall prolapse?
And there are different approaches through which we can correct. One can be vaginal, amongst which sacrospinous fixation is most common. Then, ma'am, apart from that, we can go for abdominal or laparoscopic approaches also. In abdominal approaches, sacrocolpopexy is an option, and the same thing can be done laparoscopically also. But, ma'am, because
you can do it robotic. Okay. So, what is the principle? If there is a case of wall prolapse and you are thinking of surgical correction, what is the basic idea? What do you want to do?
Ma'am, correction of the apical prolapse.
Yes, correction. So you have to somehow hold that vaginal apex and anchor it somewhere. Somewhere means where?
Sacrum.
Sacrum is the core. Whatever treatment modalities you read or you think, so easy way to understand it. Somehow what we are trying to hold the apex of the vagina and pull it towards sacrum. Now it can be done through various ligaments. So mostly there are 3 ligaments through which we can do. We cannot fix it to a bone. So we have to take help of ligament. So what are those 3 ligaments?
Anterior
longitudinal ligament. Very good. So anterior longitudinal ligament runs in front of the sacrum. That we can do, but that is abdominally. So you can do it abdominally, laparoscopically, robotically. That is a different. What way you want to enter, that we are not discussing, but that is one way, fixing it to anterior longitudinal ligament, and the procedure is known as
sacrocolpopexy.
Very good. Sacrocolpopexy. Very good. Then what second ligament?
Sacrospinous.
So sacrospinous ligament we can fix. That again will fix the wall to sacrum. So that is done abdominally. That is done vaginally. So sacrospinous fixation is done vaginally. Then one more ligament we can use. What other ligament is joined to sacrum, inserted into sacrum? utrosacral ligament.
utrosacral
Okay.
section.
So we can even do high utrosacral ligament suspension, which is a little less common, but you can do it. Can be done. It is good because without opening peritoneum, also in cases of wall prolapse, you can do it. But it has a risk of little ureteric kinking. Okay, so more popular. Though this, all studies have shown that it is as good as, it is done vaginally, obviously. So it is as good as sacrospinous fixation. But today we are not going to talk much about utrosacral. We'll discuss one approach vaginal and one approach abdominal. Which one you want to choose for which patient. So I'll repeat, sacrospinous fixation is done vaginally for patient, and sacrocolpopexy where you join the this thing, what do you call, vaginal vault, but you cannot directly pull it there. There is a lot of space, so you have to put a mesh or a graft in between. Okay, usually we put a proline mesh there and you connect it to the sacrum. So how do you choose a patient, whether you want to take a vaginal approach or you want to take an abdominal approach?
First, depending upon the severity of the prolapse. Like in this case, it is grade 4 and it is a lot, like the bulk of the prolapse.
That is not the first. What is first?
Patient profile, like if this one.
Three things I'll tell you, but first, most important, what is the problem of, okay, you will be able to answer it better if you tell me what are the advantages of vaginal procedure, sacrospinous fixation, and what are the disadvantages?
The advantages are that it is comparatively, like expertise required is lesser for sacrospinous as compared to sacro.
No, I don't trust this. If you are doing proper sacrospinous, I think it takes more pain to do it. Okay.
The stay is less, ma'am. Like recovery is faster.
Yes. So the most important good thing about vaginal procedure is actually you are not entering the abdomen. Extraperitoneal it is. So it has a faster recovery, less chance of abdominal complication. So it is a very good, you can do it a little faster than opening abdomen because you have to open, close, fix it here and there. And you are actually not using a mesh there. Okay. So the risk of complications are less and patient recovery is faster. Okay. What is the problem?
That these the severity may not be correlated with only less level or less severe prolapses.
That is relative maybe. Yes, you are right, but more important. Because every wall prolapse, Vaishnavi, won't be like what you saw. Okay, this was a case where the prolapse was very big, but most of the wall prolapses you will not see this big. So, what it does, which spine, which sacrospinous ligament you fix the wall to?
Only the right side. Yes, ma'am.
So unilateral when you are doing that, vaginal excess is deviated to one side. Okay, this is the problem. So in which women, who are those group of women where you want a good vaginal excess?
Obese women or with
who are sexually active.
Yes, ma'am.
Okay. So length of vagina and the excess of vagina you want.
Yes, ma'am. Is reduced in sacrospinous.
Maybe it is not reduced, but it is totally deviated. So they might have some difficulties during coitus. While what you are doing in sacrocolpopexy, you are just pulling it towards, and then you are using a mesh. So the length is actually quite good. Okay, and excess is more or less like a normal excess. So if it is a sexually active young lady, we prefer to do a sacrocolpopexy for her. If it is an old lady who have comorbidities, we prefer to do a sacrospinous fixation from vagina. Okay. Now we come to second point. Okay, so that is the first indication. Whatever you have seen, but that's the first differentiation. Now you remember from this case that if a patient prolapse is very big and the introcele component is huge, okay, then even if you fix it, so there you don't use a mesh, there you use one or two sutures, just a bite. And vagina is, you take bites from sacrospinous ligament and then you connect it to the vaginal vault with that same stitch. Okay, so the connection is just with two stitches. There is no graft in between. And if the patient is fat, she has lax connective tissue, which is seen by hernia, and the condition is long lasting for 15 years. and she gives so much attention to her that for 15 years she did not come to hospital. That means she's not a very good candidate for a vaginal surgery, because you repair it with vagina just with the help of 2 stitches. You are anchoring with so much weight of the abdomen with already lax and thinned out tissue. It will just cut through those sutures and patient will come back with prolapse again. That is the reason, though despite she was a diabetic, okay, she has so much obesity, she has history of hernia repair with mesh, still we went inside the abdomen and did a sacrocolpopexy for her. Okay, so because keeping, that's why you have to tailor the management here. One size doesn't fit all, so you have to see what all things can happen later on. So this is the second indication that we have to go and do a sacrocolpopexy. So in short, can you tell me the steps of sacrocolpopexy? Just in short, because this is not a procedure which we see commonly. Okay.
So now first in sacrocolpopexy, usual approach is through a fan and steel. Although in this particular, because of our previous
This
incision,
doesn't matter, like, because we are used to doing fan steel and there only pelvis it is, you can give midline also.
So after abdominal incision and adequate exposure, then we try to basically dissection of two spaces, that is the pre-sacral space, that is posteriorly, and anteriorly the subpubocervical fascia, that we have to dissect two fascia. The rectovaginal.
So anteriorly you have to fix vault with sacrum.
Sacrum.
So anteriorly you have to clean the vault, and posteriorly you have to clean the sacrum. Okay.
Yes. So anteriorly, to make the vault available, that pubocervical fascia we dissect, and there we create
so there
a
is
space.
anteriorly is pubocervical, posteriorly is rectovaginal. So what we do, so how do you know that it is, because prolapse is outside.
Yes,
so how do you know that where is the bladder, where is the rectum?
And with the help of a vaginal manipulator, we identify first that where is the vagina and where is the pouch of Douglas. Both we identify, and accordingly we go dissecting.
So you only were doing that, and what you did, you tell the truth. You put a sponge holder, you take one piece of sponge longitudinally in a sponge holder and push it inside. That's what you did?
Yes, ma'am.
Okay, so you do that, you will see a bulge there. That is the vault. Now anatomically we know that anteriorly in the vault bladder is stuck, and posteriorly there is sigmoid fold of pouch of Douglas, what you call it.
Yes.
You just have to pick up the peritoneum and cut it. Okay, and start dissecting the bladder anteriorly and the bubble posterior, whatever is attached. We have to free a space of around 5 centimeters in front and 5 centimeters behind. Okay, that much space should be cleared, and you should be very careful when you are dissecting laterally.
Yes.
Why?
Ureters. First, as a landmark, you have to keep ureters. Dissect
So we'll go.
then.
Actually, we do it later. First, what we do usually, first we clear the space where we want to approach the sacrum. So where do we open the peritoneum here?
First, we identify the right ureter.
Very good.
And beneath that, we the peritoneum. We'll dissect the fascia and create a space. Following which, we'll approach medially and start incising the peritoneum. And
so it is very simple. Okay, that patient we had difficulty because she was so obese. It was difficult to do things in that. But usually, if the patient is thin and good, what you have to do, you have to see the right ureter. Pack all the bubble and enter your abdomen. Take out bladder, everything in another retractor. You will see the sacral hollow. Okay, you see the sacrum, and then you come to the right side where the surgeon is standing. You trace the ureter which runs on the right side, and the other side is the sigmoid colon which comes from the left side. You lift with one long artery, peritoneum in between two, and give a lick. Go posteriorly, you will reach the sacral promontory. Go anteriorly, you will reach the vault. So peritoneum is reflected both sides. Okay. Anteriorly, you have told how we dissect the vault. So 5 centimeter anteriorly, 5 centimeters posteriorly. You have to dissect. You don't have to create any other space. Always remember, more dissection, more problems. So do whatever is required. Don't do too much. Too much of anything is not good. Okay. Then go behind in sacrum. Which part you want to dissect? So the safest area is between sacral promontory and S1. Okay, it might not be the best area, will be optimal to maintain the vaginal access is S2, but we don't want to go to S2 because below S2 the venous plexus, midline sacral venous plexus is very scary. Okay, so the safest zone is between the sacral promontory and S1 vertebra. That also not in the midline, on the side.
On the side.
Because anterior longitudinal ligaments are not on the midline, they are on the side.
Sides.
Okay. And midline, there are middle sacral
Sacral
vessels, artery are there, vein is there, and a lot of plexus of presacral vessels, venous plexus is there, which is very scary. If you touch that, it bleeds, then
It is very difficult.
it is very difficult, it is life-threatening. Why? Because these veins will bleed, and by the time you are trying to catch them, they retract into sacrum. Okay? Then you have to put bone cement, you have to do, and patient, it is very difficult to save the life. There is a difference between this bleeding, which we see in sacrocolpopexy, and what we see below in sacrospinous fixation. Sacrospinous fixation is just simple venous ooze of pararectal space, and if you just give pressure, it will stop. You don't have to. Like similarly, when you are doing Birch-Kolper suspension, so you have to remember which venous bleeding is more scary. Okay, so if you are just dissecting the retro pubic area, space of Ritzius for Birch-Kolper suspension, that area also bleeds, but it just requires pressure and packing, and it will be fine. Similarly, rectovaginal space also same thing, but here presacral veins or presacral venous plexus, as you said, if it starts bleeding, the vessels will get retracted inside the vertebra, then you cannot do anything. Okay, so let's not do that. Okay, so you remain on the side, you don't go below the level of S1, so remain in the first segment of sacral vertebra. Clean it with all the fat and whatever loose area tissues there. You will see glistening white ligament, which is attached to the bone. So you cannot lift it up. It is just tightly attached. If you are lifting something up, that means it is either peritoneum or sigmoid colon. Okay, so it will be tightly fixed, and you take some bites there. How many bites you should take? Three. So 3 to 4 bites. Actually, 2 to 4 people say that. Theoretically, it's enough. You should not try to take too many bites also, because you just want to anchor the mesh. If you take too many bites also, it goes into the periosteum. Okay, there is a risk because ligaments are not that broad, and you have more chances of injuring the vessels. Okay, and then if it goes to periosteum, then it gets irritated and patient will keep on having backache, it can get infected. So 2 to 4 sutures is the ideal. Even 2 sutures if you are able to take, that's good enough to anchor a mesh. Okay, so how many sutures we took?
We took
in between, we took 3 sutures. Okay, which suture material you should use here?
We used Ethibond.
Ethibond. So any non-absorbable will do. Okay. So in sacrum, when we are putting sutures, we should preferably put non-absorbable. When you are putting at the vault end, some sutures, there you can use delayed absorbable. PDS also you can use. You can use non-absorbable also. But when you are taking the bite, it should not go through and through the vagina. Okay, this is the rule. Now, after dissecting, now both planes you have dissected posteriorly, anteriorly, and you have put 3 sutures or 4 sutures in the anterior longitudinal ligament. Now, what do you do after this?
We take a mesh.
Very good.
So, proline mesh, like in our case. So, around, they say 14 into 4. We took 15 into 4. We folded it into and created.
Because you have to again shape it, okay? And you have to trim it. So, even little longer mesh, because ultimately it has to be patient-tailored mesh. Okay. So, it has to be Y-shaped mesh. So, one longer limb of Y should go to the sacrum, and one front leg should come in the front between the bladder and the vagina, and posterior limb should go between the pouch of Douglas and the vagina. Okay. So how do we make? We do not, like, you have already actually Y-shaped meshes, but they are very, very costly. So we do a cheaper alternative. We make the mesh, and what do? We take a hernial mesh, and hernial mesh is a square. You fold it, okay, and then cut the lower part. Okay, and suture from the other side, so it looks like a Y shape. Okay, so you anchor it behind, you anchor it
in the front.
First we anchor in the front, then you check for the tension. Should it be too tight? No, never. Okay, so it should be loose, because little fibrosis will happen. 30% of strength the mesh will get because of the fibrosis later on. So if you have already made it very tight, and then 30% fibrosis, then patient will have, the bowel will get pulled, the bladder will get pulled up, then patient will start having problems. Okay. We don't want that. Then after this, once the mesh is in place, you have tailored the mesh, you have cut the mesh, done everything. Now comes the most important step. Like many steps are very important, but this is again one very important.
Peritonization.
Very good. And what peritonization?
Double
Double peritonization. So first peritonization is
closing the spaces that we have, the peritoneum that we've created. Second is the cul-de-sac. Also, we have to do the second.
no. So first mesh. See, mesh has one limb gone up. So this entire space you have
Yes,
to
ma'am.
close.
Yes.
But you also have to close the space which is in at the top of bladder and pouch of the bladder. So we have to take a purse string suture exactly the same way as we close the peritoneum in vaginal hysterectomy. We take bites all around and a purse string suture so that the mesh is totally inside. If it remains in the abdomen, there is risk of perforating the bubble and mesh erosion into the bubble, and also when band is there, fibrous band is there, it might obstruct the intestine. So risk of intestinal obstruction is there. So very, maybe you are tired after operating an old lady at the end of this, but still you spend 10 minutes extra and do a very good peritonalization, otherwise you will have problems later. And I say double peritonalization, and just limb has to be covered and the area near vault which you have opened anterior posterior, otherwise from somewhere the mesh will get eroded. Okay? So that has to be closed. Okay? Then you close the abdomen. Done. Okay. Then what happened in this patient? You were at the vaginal end.
Yes.
So prolapse. Did you need any other repair after
No.
that? No.
The prolapse had completely gone inside.
Nicely. But if by chance, usually you will not have, see all that perfect repairs where we want to repair a bit of cystocele also, every bit of rectocele. Rectocele this patient did not have. So these are young women. For them, we do it for a different purpose. And if a lady is 40 years, she has like 40 more years to live. Like this patient has, already she was 67, maybe 10, 20, 30 years, whatever she has. The perfect anatomical repair was not important for her. She just wanted relief of her symptoms, and more important, her symptom was decubitus ulcer. So decubitus ulcer, now she will not have decubitus ulcer, and whatever was remaining, you don't have to trim that. When it gets deposited back, it will heal on itself. When she comes back, you can check it. I'm very sure that it will heal, because this is because of stasis. When the thing is deposited back, it is definitely going to heal. Okay, so she did not require any other repair from vaginal end. She has got a perfect result. And now post-operative period, what you have to remember?
That her sugars have to be controlled.
Okay, because we have put one foreign body inside. Strict sugar control is very important, and I think that's it. Okay, so you told about vaginal. So we discussed basically three kinds of vault repair. One is uterosacral, which we did not discuss today. Mostly we discussed that sacrospinous and sacrocolpopexy. Okay. Now I want to ask you one thing. Have you heard of this term? So sacrocolpopexy can be done abdominally and can be done laparoscopically. So it doesn't matter. Results of both are very good, range from 97 to 100% results. And you have to try to prevent all complication, because the risk of complication is a little bit or quite high as compared to the vaginal procedure in these. So because the complications are so many, so one very important complication is that sacral venous hemorrhage I told you. Okay. So to prevent that, so we always try to find out simpler ways to prevent complication. This is what we do in medical science, or especially in surgical fields. So one new surgery has come. Have you heard that name? Yes, so new things all Vaishnavi and these videos know. Okay, so that new surgery is known as pectopexy. And what do you do in pectopexy? You don't go to sacrum. You lift the vault of the vagina and you attach it to the pectineal line, iliopectineal line. Okay, so you have to go along the round ligaments actually, and then you have to dissect a little bit. So that is very safe area. There is no venous plexus there. There is no vital organ there. Nothing to worry about ureter, no bowel there. So that is the safe area. Okay. But the problem is this pectoplasty is a very new procedure. Okay, we do not have much data. So sometimes, most of the times in surgical field, we think something theoretically and something happens in the body. Like same thing when we started retropubic taping, we thought there were more complications, so people devised obturator approach. But 10, 20 years down the line, they again came back to retropubic. That time everybody thought that, oh wow, obturator is so good, no complications, same effect. But effect is not the same, and long-term complications are also more. Okay, so people are coming back again to the retropubic approach, or we have to select our patient. Okay. So what I want to tell that pectopexy, yes, definitely it has very less incidence of complications. But again, first thing you have to fix bilaterally. So vagina will be stretched. Okay. So vagina will be stretched. So this is one negative point I always tell you the story that when I started fixing vaginal wall bilaterally, I had a very high incidence of de novo stress urinary incontinence because vagina when it gets stretched, urethra also gets stretched and fixed with that. So high risk of. So people have not studied that because the study has been in very small group of population. We have not studied or compared pectopexy versus sacrocolpopexy in a wide group of population and from wide population. Okay? So whenever we are thinking that we have to do a simple procedure, we have to take it with a pinch of salt. Okay? Because we still don't know what are the long-term complications, though it is a safe procedure. Again, when you are connecting the vault, you are not repairing. Then you have to put a mesh anteriorly or mesh posteriorly or go down and do some repair, because just holding the vault is not enough. The beauty of sacrocolpopexy is it takes both the interior. It takes care of vault also, it takes care of anterior and posterior vaginal wall also. For small prolapses, yes, it is a good technique. For large prolapse, we still have to see. Okay, so this is all about it. So Vaishnavi will summarize. It was a long discussion, so Vaishnavi will summarize 5 points what she learned from this case.
That first thing is that wall prolapse is more common these days because of more number of hysterectomies that we are having.
And more number of hysterectomies people
and
have
long-
undergone
and
and
the
long
lifespan.
lifespan.
Second thing is in examination, I'll never forget. First, identify the vault line. That is the
Yes.
key to wall prolapse examination.
Yes.
Identify the vault line, and then the approaches to treating vault prolapse. There can be like which candidate is for sacrospinous, which candidate is for sacrocolpopexy. Like younger coital function to be preserved, those are more likely like to have better results with sacrospinous. And comorbidity is also ideally sacrospinous. But in our particular case, we tailored it to sacrocolpopexy as the patient had like a large prolapse and we could not manage it with sacrospinous. So tailor
So
your
whatever,
approach.
like there is some you understood, I
Yes,
think,
ma'am.
that which patient is. I think you said one thing wrong, that for those women who are sexually active, sacrocolpopexy is better.
Sacrospinous fixation.
No,
Sacros-
sacrocolpopexy is better because it
at
gives
vagina length, yes, ma'am.
length of
Yes,
the
ma'am.
vagina
Yes,
and
ma'am.
excess of the vagina.
Exactly.
So anyway, you understood. Now when a patient comes, you have to sit and think with procedure you
Which
want to.
procedure?
So you cannot say wall prolapse, I'll do this procedure. No, you have to sit and think which procedure is best for her. Okay, and depends on surgeon's expertise also.
Then double peritonization
Very good.
in
In
sacrocolpopexy.
and one new surgery. You knew it before only, but maybe when you become a big urogynecologist or gynecologist, you can do some comparative study here, pectopexy versus the other methods. Okay. So anyway, it is upcoming. We are not saying that it is a bad technique, but we need to see the results in long term. Okay. So I think this was a good discussion. Discussed a lot of points. I hope it helped. Thank you so much.